This is the eye assessment specific to the pediatric patient and is to supplement what you've already gotten in your physical assessment class. This is just a review, and you've had this before, probably both in your pathophys class and in your physical assessment class. But it's really important, as we're talking about the things that can go wrong with the pediatric eye exam, that you remember the anatomy and physiology of the eye. So remember that the lens is what bends the light rays, and the choroid is the muscles, including the iris, that helps focus the light. The pupil is the hole where the light passes, and it's controlled by smooth muscles. The retina has both the rods and the cones. The rods mediate the peripheral and the dim light vision, and the cones are your color receptors. The optic disc is the area where the optic nerve enters, and it lacks both cones and rods, and so there's a blind spot there. The fovea centralis is the area with the most cones and rods and your most acute vision. And then the vitreous humor maintains the shape of the eye and is not replaceable. Now, also remember, for the eye anatomy and physiology, it's important, especially in pediatrics and the newborn, early infancy, to think about the lacrimal apparatus that secretes and drains the tears. And you have both the lacrimal gland, and you have the tears that then wash from that upper outer corner of the eye across to the inner canthus and into the lacrimal sac and into the duct draining into the nose. Also, the macula is that area around the fovea centralis, so again, concentrated rods and cones. The optic nerve, which are those medial fibers that come in at the optic disc, and then the physiologic cup is the small depression to the center of the disc. This is a screenshot of an actual retinal exam and has both your optic nerve and the fovea centralis marked for you. Now, when we're doing the eye exam, we want to think about some terminology for documenting what we're finding. And you remember EOMI means the extraocular movements are intact. Perla means the pupils are equal, reactive to light, and round, reactive to light and accommodation. And accommodation means the ability to focus the eyes to see up close and the ability to change from close to far. The corneal light reflex is the reflection of the light from the eyes, and the red reflex is from the ophthalmoscope. And then we have the cover uncover. So let's delve into a few of these in specifics. The extraocular movements intact, you want to test how strong, and how well coordinated those eye muscles are. So this is just a reference to which muscles you're using when you go in the various directions with your EOMs. Remember that you have the child or the patient look at something, and for younger babies it's fun to have something interesting for them to look at, a toy, sometimes pinwheels, that sort of thing for them to focus on, and then move in those 6 directions to see how well those muscles function. Then you're going to use your pen light And again, the younger children will usually be interested by a light, but if you have something interesting for them to look at, it's particularly useful. And as you're shining that light into both pupils, you want to see that the light reflex is coming back at you at exactly the same place in both pupils. So on this particular slide, you can see both the ceiling light reflection in the same place in both pupils, as well as your pen light reflection, both places in both pupils. So this child has a symmetrical corneal light reflex. Now, strabismus is an abnormal condition frequently picked up during the well-child exam where there's misaligned eyes. So those muscles may not be as strong or they might not be as coordinated. And the diagram on your right here identifies the physical assessment finding associated with each abnormal term. So A is normal, and you can see the corneal light reflex is symmetrical in both pupils. B is esotropia, and you can see this is an extreme case. It rarely will be that distinct, but you will see that the corneal light reflex in the right eye is on the iris instead of the pupil. And exotropia, the eye is turned outward, and again, the right eye, the light reflex is on the iris. And then D, hyperopia, it's below the pupil. The little boy's picture at the bottom is pseudostrabismus, and that's because he has what appears to be abnormal, but when you actually look at the corneal light reflex, that light reflex is exactly in the same place on both pupils. So it's pseudostrabismus, not strabismus. The next thing you want to look at is the red reflex, and you want to look for both monocular and binocular vision or abnormalities. So what you're looking for is opacities when you're looking at the red reflex, and it's indicative of abnormalities in the back of the eye. It can be associated with strabismus, and your technique, remember that you're going to turn the light off in the exam room, and your ophthalmoscope needs to be 12 to 18 inches away from the child in order to do this examination appropriately. Here is how you'll start the exam, and you will start a little farther off and get that red reflex and then move in closer. And this little boy in the bottom picture here has positive red reflexes captured in the photograph. You can see both have a glowing red hue to the pupil. Now let's refresh your memory on eye development. Vision is only 2400 at birth, and the blink reflex is not even present in the first few months of life. At 6 to 10 weeks, we expect the child's eyes to begin to move synchronously, and they should be able to fixate on the face and objects. At 6 months, the child begins to have pretty good vision, and both the macula and the fovea are beginning to mature. The child should begin to have some accommodation, convergence, and some binocular vision. That's when we start to see a social smile, because the child can actually see the parents smile and will smile responsively. And we also expect those ocular motor muscles to begin to mature. By 2.5 years of age, myelinization of the optic nerve is complete, and up to the age of 7, we can still have vision being normal at about 20/30, but after 7, at 7 and above, we really want them to be 20/20. And remember that the eyes are still pretty malleable until age 7 to 9, but we definitely want to refer for any abnormalities by that age and have them corrected. Now, when you're getting the past medical history related to the child's eye, it's critically important to know if there was any substance exposure during pregnancy. We know that both infectious diseases and medications can have adverse effects on the developing eye in the fetus. We're particularly tuned in to what's termed the torches exposure, and that includes the diseases listed on your slide, but of course toxoplasmosis. The other stands for syphilis, varicella, parvovirus, rubella, CMV, and herpes. All can have detrimental effects on the developing eye. We also know prematurity, and in particular, it's premature retinopathy of prematurity related to high oxygen exposure in the very premature infant is worrisome. Any developmental delays should be a signal to carefully evaluate the child's eyes. Any neurological abnormalities, any metabolic problems, congenital or genetic problems. Allergies are important, and we also want to know when the last eye exam was. Family history is important as well, and if there's any family history of congenital anomalies associated with the eyes, any family history of blindness, retinoblastoma, metabolic, genetic, or congenital disorders that involve the eye, need for corrective lenses in family members, glaucoma, blood dyscrasias, hypertension, any of those things that could have implications for this child's eye down the road. And then we want to focus on age-specific concerns. So in the infant, we want to ask about it. Does it look like the child can see you? Does the child pay attention to your face? Do you ever notice a wandering eye or crossed eyes? Does the child have excess drainage from their eyes? Is the child ever inconsolable and crying and rubbing at their eyes? Frequently, children will have corneal abrasions that are extremely uncomfortable, and the only symptom is irritability. Persistent tearing is consistent with the lacrimal duct blockage, and certainly a white-red reflex is concerning, or any child who doesn't have eye contact by the age of 3 months is worrisome. For the toddler, we're really focusing on whether or not they have good extraocular eye muscle movement, and have they noticed any wandering eye or crossed eye. Do they have itching, pain, or discharge? Does the child squint or hold things really close? Does the child bump into things or have behavioral problems? Red eyes or lids are important. Rubbing their eyes frequently. A child who avoids coloring or puzzles or detailed activity can be indicative of problems with sight and difficulty with eye-hand coordination. For school age and adolescent, any history of blurry vision or lost vision, eye pain, headaches, infections, frequent blinking or school difficulties, a child who avoids close work or tires real easily with classwork, reverses letters or numbers, and difficulty with handwriting. And again, any poor eye-hand or body coordination can be indicative of eye concerns. So, what are some specific ocular history questions that you might want to ask the family? Start with something general, as we do with most of our history taking, and that is, does your child seem to see well? Does your child hold objects too close to his face when trying to focus? Do your child's eyes appear straight, or do they seem to cross or drift? Or does your child have a lazy eye or wandering eye? Do your child's eyes appear unusual to you? Do your child's eyelids seem to droop or not be able to open all the way? And any injuries? You're going to start your physical exam with inspection, like we always do, and you're going to look for the inspection with the lids. Is there any droopy lid or ptosis? Conjunctiva, is there both the palpebral and the bulbar conjunctiva should be clear and should be inspected. Look at the sclera, the cornea, the iris, pupils, and note any discharge. We're also going to do visual acuity, and visual acuity exams should start at age 3. If the 3-year-old is unable to perform the exam, reattempt it in 4 to 6 months. At age 4, if they're unable to do it, reattempt in a month. And if you're unable to do it after that, go ahead and refer. The best way to approach this is to have a well-trained office staff who are really good at interacting with children, showing them the pictures, asking them up close what they see and what they call it, and then engaging them in a play-like atmosphere so they want to participate in the visual acuity exam. As the child gets older, there's a variety of other visual acuity tests that you might use. Usually the pictures are appropriate for kids between the age of 2 and 4 years. Over 4 years, you can use the Snellen with the letters or the numbers, depending on whether or not the child knows their letters and which the child is more comfortable with. And then over 6, you can use the machine. The one pictured here is the Titmus, which is just another way of doing visual acuity exams. Abnormal visual acuity exams are for the child who is farsighted, it's hypermetropia, and for the child who is nearsighted, it's myopia. And you can see from the slide that it's a difference in the light focusing in different places in the retinal area that results in the abnormal vision. So this chart's just a friendly reminder of the aspects of the exam that you really want to do and the priorities for the different age group. And you really expect that, that the ability to do the more sophisticated assessment goes up as the child gets older. So you're going to inspect at all ages. You're going to assess the red reflex at all ages. You're going to expect the child to be able to fix and follow on your light or your toy from 6 months on. You're going to do some photo screening with 6 months and above. So does the child actually look at you and follow you? Is the corneal light reflex present 6 months and on? The cover uncover from 6 months and on? And then visual acuity, we're going to start to try at 3 years, but we should definitely be able to get both visual acuity and depth perception in the 5-year-olds and up. So your ophthalmoscopic exam is one that's going to take some skill to learn in children, and you're going to try it on every well child care visit. You're going to refer to ophthalmology for any concerns, particularly a child with a head injury, neurological concerns, or abnormal findings or history. This is just a reminder of what your ophthalmoscope looks like and the components that you may use for the ophthalmoscopic exam. And remember that your large light is probably only going to be used if you have a child with a dilated pupil. The medium or small light are going to be better for your retinal exam. Your red-free light is more when you're looking for hemorrhages, and the grid is good for documenting where you're finding abnormalities during the ophthalmoscopic exam. The most critical thing to remember is that when you're actually looking at the retina, you cannot do that well unless you're very close to the child's eye. And so you can see this exam, she is adequately close to the adolescent's eye that she's examining. I think technique-wise, I think her hand should be on that young man's forehead so that as you move in, you will run into your own hand, not into the young man's forehead. And remember that your right eye examines their right eye so the noses don't bump. But this shows adequate distance, not ideal technique. Okay, so let's start with case number 1. And case number 1 is a young man that I actually saw at the Sheridan School-Based Health Center quite some time ago. And Jeffrey is a 6-year-old first grader at Alice Terry Elementary, goes to school one day with a red eye, and the school nurse calls the clinic to see if we can see him, if she can get the mom to bring him in, because the school nurse is worried he might have conjunctivitis. He showed up today with this red eye. So as we start this case, I'd like you to think about what questions you have that you want to ask in the history when you're evaluating a child with a red eye, and specifically this little Jeffrey who comes into your clinic today with the red eye. Think about what questions in the history you want to ask. Jot a few ideas down, and then we'll advance to the next slide to see if your questions and my questions are the same. So with the history of a red eye, we want to ask all the typical history questions. When did this start? Were there any precipitating events? How are things progressing? What's the duration been? Especially important with a red eye to know about the child's allergy history. We want to know if there's been pain or itching. Has there been any sensitivity to light, or any drainage or tearing, any extraocular eye movements, or sensitivity with moving his eyes, any visual disturbances, past eye problems and treatment, any associated symptoms, and any exposure to conjunctivitis, as well as any trauma. So this mom reports that the child has had this red eye for 4 to 5 days. There was no history of trauma, but she reports they live in a trailer park on Santa Fe and there's a lot of construction going on. He's constantly being exposed to dust from the construction. He rides his bike outside a lot, but he's never really complained of getting anything into his eye. The child denies any pain, but the mother notes that he rubs that eye a lot. When you ask the child, he denies both pain and itching. The mother states there's been no drainage and she hasn't noticed any watering or tearing. Mom hasn't noticed any changes in eye movements. The child denies visual disturbances, but he does have a very marked decrease in visual acuity when you do the Snellen chart. The red eye has 2100 and the normal eye has 20/20. There's no history of previous eye problems, the child has no allergies, and the child denies any associated symptoms. There's not any known exposure to conjunctivitis, but he is a first grader in an average size elementary. So think about this case. What are your differentials? So, what is your differential diagnosis for this kid? So common differential diagnoses that you want to include for this child are conjunctivitis, which is defined as the redness of the conjunctiva. Pain is usually minimal. Vision and pupil size and reactivity are normal. So the fact that he has decreased visual acuity makes us lean against that. And acute glaucoma usually has pain, decreased vision, a cloudy cornea, sluggish pupil, moderate bulbar injunction near the limbus. Iritis has pain, moderately decreased vision, dull and swollen iris, sluggish pupil, bulbar injection near the limbus. Lacrimal duct obstruction, pain, redness, and erythema around the lacrimal sac. His lacrimal sac was fine. Blepharitis, similar to conjunctivitis with inflammation of the lid. His lid is fine. Corneal abrasion is the history of trauma with bulbar injection. So that's a possibility. And Kawasaki's, which is associated symptoms of fever, sore throat, and rash, none of which he had. So on physical exam of this little guy, we want to pay close attention to the external eye. His eyelid, lashes, surrounding tissue and structure all look fine. The internal eye, his cornea looks fine. His pupils are a little bit sluggish on that red eye and pretty brisk on the non-affected eye. And his bulbar, it's hard to tell if it's the conjunctiva that are red or if it's underneath the conjunctiva. His eye is red, but the palpebral conjunctiva are clear. And then we did rule out a corneal abrasion with a fluorescein stain in the Woods lamp. And looking at his pupillary reaction shape, equality, direct and consensual for accommodation and convergence, as I said, the affected red eye had just a slightly bit more sluggish reaction to light. EOMs were intact, peripheral vision was okay, visual acuity was decreased, and ophthalmoscopic exam looked pretty normal. So now, narrow down for me what you think the possible diagnosis for this child is. And what your next steps might be for this child. So jot down what you think the diagnosis or the potential, your top differentials are for this particular child. So this particular child had iritis, and this slide is a classic picture of iritis with the real injected redness right around the iris, which is not at all what this young man looked like. He really had a red sclera all across. But iritis also will have that sluggish pupil, and anytime you have a decreased visual acuity and any question of decreased pupillary constriction or just inequality of pupillary constriction, those children need referral. Some other common eye abnormalities that you're undoubtedly going to see in primary care are strabismus, which is malalignment of those eyes, and that's usually caused by a weakness of eye muscles and lack of coordination of eye muscle movement. Those children need to be referred because if it goes untreated, it leads to a loss of vision or the amblyopia, where the brain cannot process the visual cues and does not create a clear visual image because of the lack of coordination of those two eyes working together. Deprivation can be a unilateral obstruction of vision because of a ptosis or a hemangioma or tumor or something like that, maybe potentially some corneal scarring. And again, those children need referral so things can be corrected before there's a permanent loss of vision. And then, of course, it can be refractory, which is cases of like myopia, hyperopia, or astigmatism. So here's a slide with an extreme case of strabismus. But as you know, you're going to do your cover-uncover test. And as you hold something occluding one eye and shine the light in the other eye, you will quickly move the paper or hand or whatever that's occluding the eye away. And if the child has strabismus or a wandering eye or a lazy eye, you will see that the corneal light reflex will not be equivalent in both eyes when you quickly move what's occluding that eye. And this is a classic picture of strabismus. Anisocoria is another abnormality that you may see in practice, and it's an unequal pupil size. If it's 1 to 2 millimeters in size and it remains the same in both light and dark, it can be benign and no referral is needed. Otherwise, these children should be referred. Anisometropia is asymmetrical visual acuities between the eyes, and if it's more than 2 lines on your visual acuity chart, the child needs referred. This is a child with ptosis, and usually if it's mild ptosis, so that the lid is drooping but not at the level of the pupil, it's not usually a big deal. If it's at the level of the pupil, it can interfere with vision, and the child should be referred. Astigmatism is unequal curvature of the refractory surfaces of the eye, and it can again influence visual acuity. It's most commonly found between 6 and 9 years of age and should be referred. Cataracts need immediate referral. In children, cataracts can be either congenital or acquired, and many times go along with other congenital anomalies and or infections. Here are a couple other examples of cataracts that you may encounter. Now let's move on to case number 2. So Sally's a 2-year-old girl who presents to your office with bilateral pink eyes. Her mother states the redness started in the right eye 2 days ago, followed by the left eye today. This morning, the kid's eyes were stuck together upon wakening. She used warm compresses, applied to both eyes to get them open. The child has not complained about pain. There's been no nasal drainage or fever. She has not had a cold or sore throat lately. No other family members have had this problem, and the child does not attend daycare. There's no known allergies, and she's not taking any medication. Think through what you think might be the differential for this little person based on that history. Now, thinking about this child, what components of the physical exam are important for this case? So this child on physical exam had a reddened eye with the mucopurulent drainage. The eyelids were swollen. There was redness of the palpebral conjunctiva, which line, the upper lid and the lower lid. There was edema of the conjunctiva. There were little petechiae on the bulbar conjunctiva. It looked like little minor hemorrhages on the it looked like on the sclera, and then enlarged preauricular lymph nodes. So with this additional information, which of your differentials would you eliminate and which would you elevate to the most likely cause of this child's reddened eye? So think about what your differential diagnosis is and how you came to that conclusion. So when we think about bacterial conjunctivitis, we think about that mucopurulent drainage, the crusting along the lid margins, the eyes stuck together in the morning, that thick green mucoid drainage. Viral is very often non-purulent. And the bilateral involvement with the onset in one eye and spreads to the second in a couple days is pretty classic with bacterial conjunctivitis. So what else needs to be ruled out before this child leaves your office? Give a few seconds thought to what other critical parts of the exam need to be conducted. We know that a concurrent otitis media can go along with bacterial conjunctivitis, and so you need a very careful assessment of both ears, both tympanic membranes for color, for any purulent drainage behind the tympanic membrane, and for mobility. So make sure you rule out otitis media before they leave. This particular slide just reviews for you the signs and symptoms of conjunctivitis, and the left-hand side has a normal conjunctiva, the bulbar, the inflamed conjunctiva, and then some actual photographs with both the reddened conjunctiva, bulbar conjunctiva, very red, and the purulent drainage. Two examples of bacterial infections or bacterial conjunctivitis that you may see in the neonate are the gonococcal infection that can be seen in the neonatal period, and also chlamydia. And chlamydia can occur in that first 28 days of life. GC, we treat prophylactic eye drops to prevent that one, but chlamydia, sometimes there are no signs at birth, and it can develop. Any bacterial conjunctivitis that appears in the first year or month of life, you should suspect chlamydia, and certainly GC if the prophylaxis wasn't provided. Additional eye abnormalities that you might encounter in primary care include glaucoma and abnormalities of the iris. And so let's talk about a couple of those now. Here's congenital bilateral glaucoma, and you can see the opacity as you look at the lenses on this child. This is an example of some abnormalities of the iris, and this is heterochromia. Look carefully at this patient and see what other eye abnormalities you notice. There are at least two more. Can you come up with them? Anisocoria, so the unequal pupil, and also the corneal light reflex is asymmetrical, perhaps because of the unequal pupil size, but you should document all of those. And these pupils are so different that this child requires referral. This is a slide with the Lish nodules, and this can be associated with neurofibromatosis, and this child requires referral for that. This is a coloboma, and you can see the abnormality in the iris, the hole there, and this child requires referral as well. Other eye abnormalities you may note are leukocoria, which is the white or abnormal red reflex and can go along with significant health problems, nasolacrimal duct obstruction, which is far less worrisome, and then nystagmus, which you're going to refer if it occurs after the age of 3 months. These are some examples of leukocoria, and very often can be a sign of retinoblastoma. These children need referral and evaluation. Nasolacrimal duct obstruction is a common thing that we see in primary care, and especially in the newborn where that lacrimal duct might just be really small. It can be pretty benign, and we just teach the parents to treat it by corneal abrasions are also common in primary care, and you will evaluate with a Woods lamp and the fluorescein stain so that you can actually identify the area of the lens that's scratched and or the cornea that's scratched. These heal up within 24 hours, and so if the child is still having pain, they need to be reevaluated to see if there's a foreign body tucked away on that lid that's re-injuring the eye. Ocular foreign bodies are pretty common, and these are some slides that show those. You can see on the right upper hand picture that there's a foreign body tucked away on that upper lid, and again, if that's not removed with just a little Q-tip and a little saline, that will continue to re-scratch the eye. We also worry about subconjunctival hemorrhages, and unfortunately this goes along with trauma, sometimes shaken baby syndrome, and these patients have had significant trauma and need to be evaluated further for other areas that may have hemorrhage, including their brains. This is hyperemia and a ruptured globe. This is a critical emergency as well. 911 off to the ER. Papilledema also is an emergency. These children are also going to have other abnormal neurological signs, but this is a 911 off to the ER as well. Retinal hemorrhage and detached retina also will be seen with shaken baby syndrome. We'll also have other neurological signs, and again, these children are usually critically ill and need to go immediately to the ER. So as we begin to wind down here, you're going to send children to the ophthalmologist for further evaluation. If there's any abnormal screening, any signs and symptoms of eye problems by history or concerns of the family, any general health problems and systemic disease that can cause eye disease and visual abnormalities, including exposure to medication, either as a child or in utero, family history of conditions associated with eye or vision problems, and any other concerns you have.